Dr. Jyotidev. So this is a symposium on AGIs. As our chairpersons rightfully said, we are discussing starch, carbs. We are a carbohydrate country, and this is a Bayer-sponsored talk which makes acarbose or glucobay. So fundamentally, where do we place alpha-glucosidase inhibitors in an era of GLP-1 receptor agents, SGLT2 inhibitors, etc.? So one thing is very clear-cut: we are all Indians, Asians. We are different from Western population. So that I think all of us know that. We also know that we all, because we eat more carbs and less proteins, we have a higher excursion and area under the curve of the prandial glucose. Obviously, our guidelines in India and China are different. There's a lot of scientific rationale for AGIs. In fact, in China, the number one prescribed drug in any category is acarbose. And then, of course, how do you place them in the modern diabetes management? As I told you that we as Indians or Asians lose our first phase of insulin as the first metric for type 2 diabetes. That's lost first in the first 10 to 15 minutes compared to, say, Caucasians. And we have a higher glucose curve after a meal. Because we eat, biscuits, meals, cereals. We are a cerealized economy. Whether it's wheat in north of India or rice in south of India or coastal India, we are a cerealized economy. And Bob Henry published this in Singapore, where he had unique opportunity to study Malays, Chinese and Indian population from south of India in Singapore, and he clearly showed those reds where you see the prandial curve. Our chairpersons, Dr. Anil and Dr. Murali, were introducing the STAR study which I published across India. Across India, we can see non-diabetics also, most of it is carbs, then fats and very less proteins. And in the diabetic population, the story is no different. So we are a very carbohydrate country. And from our study, we showed very clearly that majority we have carbs, we have a higher prandial glucose linked to carbs and across all zones. In fact, central India has highest carbs. So clearly dietary risk is one of the factors which controls diabetes in Indian population. And we know that despite of so many new medicines, the deaths due to diabetes have tripled. And it's all because of excess fat, excess BMI, low fiber, low fruits, nuts, seeds, whole grains, and high glycemic index food and tobacco. And that has blunted our economy. Compared to the Western population, where Professor Louis Meunier showed from France, fix fasting first. If your A1C is above 8.5, then you have to fix the fasting. If it is below 8.5, you fix the prandial glucose. That is a typical Caucasian pattern because they eat 2 meals, they have an early supper in the evening. While Asians, it doesn't matter. It is prandial glucose, prandial glucose, prandial glucose, and then comes fasting. And as the prandial glucose goes up and the waves go up, clearly lipid goes up, oxidative stress goes up, LDL gets more oxidized, endothelium stress goes up, and we clearly get endothelial dysfunction and heart disease, carotid artery stiffness, arterial stiffness, and heart disease. So worldwide, whether it's IDF, India, Asia or China, there is in the guidance, we clearly recognize post-meal glucose. IDF recognized it much earlier and said diet with low glycemic loads and non-pharmacological or pharmacological therapy which target post-meal glucose should be considered. Our own ICMR guidelines recommended the use of AGA with metformin in the combination therapy as an appropriate guideline, and so did the RSAGI recommendation, which also said prandial glucose is an important tenet, and in fact they included acarbose as a part of their recommendation. If you look at the Asian guidelines from China and Korea, they again have an integral part of their guidelines, alpha-glucosidase inhibitors, and therefore when it comes to prandial glucose in Indian diabetic patients, we need to block the starch. These are starch blockers for the AGIs. Acarbose is a biotechnology compound made by a biofermenter, and we know that there is no generic in it. It slows down the carb absorption from the small intestine. It delays the intestinal carb. It lowers post-meal hyperglycemia. It leads to lesser insulin release to protect the beta cells. It improves insulin sensitivity and actually facilitates the GLP-1 release and gut symbiosis. So it alters the gut microbiome as well as inbuilt 2 to 4-fold increase in GLP-1. And therefore, one of the first studies of CV outcomes done in 1999, before CV outcome trials became popular, was a study called Stop NIDDM trial. That time type 2 diabetes was called as and that was done in IGT from Australia and China. And you can here clearly see that acarbose has a reduction on cardiovascular risk. They maintain vasodilation, they improve the bioavailability of nitric oxide, they reduce superoxide production, they reduce formation of atherosclerosis enhancing fractures, stabilize plaques, reduce cytokines, so on and so forth. It's all published data. It has insulin sparing mechanism, no risk of body weight gain, no hypoglycemia, and with minimal risk of hypoglycemia, this insulin sparing mechanism translates in clinical benefits. We published this data sometime back, almost in 2014, 11 years back, that without acarbose, you could see the carbohydrate gets absorbed and the GLP-1 gets blunted. When you give acarbose, you can see that the GLP-1 receptor agent goes up, and clearly you can see that data when it stimulates GLP-1 60 minutes due to the unabsorbed carbohydrate being pushed down the small intestine. So consistently, it's more than 30 years old now that acarbose was approved for type 1 diabetes in 1999. It was launched in 1997. Stop NIDDM trial was a CV outcome trial in 2002. It is the only agent then approved for IGT in 2006. 2009 it was approved with the FDC combination. 2012 it was in the IDF algorithm. We published our study in 2013, GLOBE and real world evidence and FDC's evidence. So it's clearly effective. It drops the A1C by around 1%. That data we have shown. If you use it in combination, the data is much more stronger. You can see here that if you compare the glycemic variability of acarbose, again you can see the mean amplitude of glycemic excursion. CV events are much lower with acarbose. It's a very fast acting drug. When you add acarbose to metformin and vildagliptin, you can see again it reduces the intraday glycemic variability. When this was a study published in 2018 in JCN, which documented CV benefits of acarbose, and clearly you could see from that study that there's a lower risk of acarbose metformin on hospitalization due to stroke, atherosclerotic events and MI, all the three. So in the Asian population it really matters, and the data on CV outcomes was all collated in Frontiers of Nutrition of acarbose on CV risk factors in IGT and diabetic patients, and a meta-analysis was published as well. There are a lot of rationale for combining metformin and acarbose, because metformin is predominantly working on the liver at night on fasting. Acarbose works on prandial. Both have insulin sparing effect. Both increase the physiological GLP-1. No risk of body weight gain, no hypoglycemia, CV benefits and lipid benefits. The GLOBE study is another observational study which is also published, very, very clearly recognizing the glucose outcome. And you could see the START-AM study also shows that in FDC population, it is pretty robust. And the results clearly show that it's well tolerated. Of course, flatulence is a well-known side effect, and we clearly recognize that alpha-glucosidase inhibitors, compared to all other anti-diabetic agents, show a very comparable glycemic efficacy with various agents. Placing the agent right is very, very important. We know that acarbose, like AGIs, not only lowers glucose independent of the age. Whether you are 19 with type 1 diabetes, whether you are 40 with IGT, whether you are 45 with newly diagnosed type 2 diabetes, whether you are 50 with 3 years of diabetes with a lot of carbs, you can use it anytime. Even in the Singapore guidelines of diabetes in pregnancy, it is lifestyle first, it is metformin or acarbose, and then it is insulin. It's a category 2 drug in pregnancy. So age, background therapy, duration of type of diabetes, baseline A1C, condition of beta cell, insulin sparing action and BMI, it can be used universally. It's a very easy agent to use with the first morsel of food, and we recognize that very clearly. If you look at the RSHDI wheel also, it's an ideal agent for a geriatric population. For example, somebody wants to do cataract surgery next week. First time that elderly gentleman has found that he has mild diabetes, you start him with acarbose 25 milligram 3 times a day. In 3 to 5 days, his glucose will be under control. You will be able to put him out for a cataract surgery. I'm just giving you an example with advancing age, geriatric population, frail population. Increased BMI, it's a starch blocker. Duration of diabetes, short duration, intermediate duration, long duration, you can use it anytime. Whether heart disease is present or absent doesn't matter. With established CVD, it has impact. It's accessible and affordable. It actually will blunt that worsening glycemic control. If you have an agent on other agents and you are still having brittle diabetes, just add a little bit of acarbose, it will make a difference, and no hypoglycemia. It's the most widely used AGI, over 25 years, approved in 117 countries, approved in 1997 in India. It approved for type 1 diabetes as adjuvant. A lot of type 1 diabetics who have a lot of glycemic variability, if you just add a starch blocker, it makes a difference, including GDM. So summarizing, because I thought we might take some questions, we as Asians have a different phenotype and different dietary patterns compared to Western population. We showed in our STAR study that Indians have a higher simple and complex carbohydrates, therefore higher prandial glucose load. There's a documented data, public health, epidemiologically, as well as with RCTs, to show that the prandial glucose induced glycemic variability contributes to macrovascular complications and cardiovascular or heart attack risk or stroke risk. Asian Indian guidelines and Chinese guidelines, as well as global guidelines like IDF, address prandial glucose and blunt that glycemic variability and get AGIs. Acarbose not only reduces prandial glucose, but reduces the need for postprandial insulin and therefore improves beta cell function indirectly without any hypoglycemia weight gain. And it is studied with a lot of robust scientific evidence, including CV outcomes. And it can be used on a broad range of persons living with diabetes on the profile, including type 1, type 2 or GDM or IGT, and has been officially approved for most of it. Thank you so much for a patient hearing.
Thank you. Thank you very much, sir, for this.
So in GDM, my recommendation is lifestyle first. Okay, metformin and acarbose, I only preserve it if patient is reluctant to use insulin. Because our guideline in GDM is keep the fasting below 90, postprandial below 120. And many a times, all you need to do is split your meal into two, and in Singapore it is approved as a category 2 agent. See, all OHAs, whether it is glibenclamide, acarbose or metformin, are approved as category 2 agents. So there is a little bit of risk. So you have to explain the risk to the patient and say, we can try this, but we always prefer insulin. That's how the recommendation goes. But it can be used. It's not that it can't be used. Safety is very well documented. It's safe. As I said, it's category 2.
Thank you, sir, for being ahead of time, and so we can take a couple of questions from the hall. Well, to start with, sir, regarding acarbose, we know that the absorption of acarbose is limited, not much is absorbed. Then why is there a safety issue in pregnancy, especially when the placental
transfer? There is no safety issue. It's a category 2 indication. So category 1 is no agent, including human insulin, not approved as category 1. Even for human insulin, there is a mark.
Yeah.
Okay, so that is something, but now those pregnancy category A, B, C have been now removed. Okay, so if you ask me, in Singapore it was listed in their guidance. In India we are not listed in our guidance because we have not looked at using it in that. Rakesh is saying something? Yes, flatulence.
Can we replace it with ripaglandin, or otherwise can we eat it hormone therapy?
So ripaglandin is a short-acting sulfonylurea. It can cause hypoglycemia. The other use of acarbose, because you asked about ripaglinide, is that acarbose can also be used in reactive hypoglycemia and people who have bariatric surgery who go into low sugar attacks. So it's a very good agent to be used for that also. So ripaglinide is a short-acting, like a sulfonylurea-like agent, but the problem is after 4 or 5 hours you might get into a low sugar attack also. So there will be a little glycemic variability.
What difference between acarbose and voglibose? Both are...
So acarbose has all the evidence. Voglibose has no evidence. In India, voglibose is very popularly used
nowadays.
Now most of the combinations with voglibose are banned by the DCGI, and we need to be mindful of that. While acarbose is a biotechnology component, very difficult to manufacture, the profit margin in acarbose for Indian generic manufacturer is very less. And that is why they don't put all that, they have put all their money in voglibose. Voglibose also can be sometimes toxic to the liver. It's only approved in 4 countries in the world, while acarbose is approved in more than 100 countries in the world. So it's a very safe agent. It's a German compound, but most data came from China, Japan, Korea and India.
Thank you so much. Thank you.
So most of our patients have a whole load of medicines. At what stage would you say that acarbose is no longer beneficial and you will take it out of the list? Or will you
So
continue?
first is if the patient is intolerant. Second is, of course, in polypharmacy, you need to give acarbose with the first morsel of food, or in between food or immediately after food, but preferably in between meals. So if the glycemic control is not there and the C-peptide is not on board, you can always take it out. The advantage of acarbose is that if your diet is rich in carbs, particularly simple carbs, it will always work. That's the advantage of it. The disadvantage of it is, if you don't start slow and go suddenly to the higher dose, you may get a GI upset. And if you don't give it correctly, you will not get the optimal effect. So if you are having, say, a idli dosa in the morning and take the acarbose, it will work very well. But if you are taking a protein first, fiber second and carb last, it may not work very well. So the way we eat our traditional Indian food, it works very well. But if we are sequencing that, it may not work perfectly well. So you need to be a little mindful. We'll need to do a little deep diving. But yes, and every drug has non-responder. So it's not that just for acarbose. Every drug has non-responder.
So that takes us to the dosing of acarbose, because we know that it's a dose-dependent HbA1c reduction.
Absolutely. So the dosing should be 25 milligram 3 times a day with first morsel of the food, go up to 50. In the stop NIDM trial, the Chinese population use 100 milligram 3 times a day. But we in India, we only use 25 and 50 with metformin. And with metformin, there is synergy.
And what about in pre-diabetes now?
It is an officially approved agent with pre-diabetes. It was approved much before. It was the only agent approved for pre-diabetes. Metformin approval only came a couple of years back.
And one more thing interesting about acarbose is we know that about anti-aging properties. There is a few studies about anti-aging properties of acarbose. Does it really work? And
so that I don't know, but there is data, Japanese data, to suggest that it might have anti-aging, just like metformin. Again, so metformin and acarbose are like, cousins with similar impact, with a lot of pleiotropic effects. And the Asian carbohydrate population, they are designed for that. So these are our drugs designed for our diets and our population.
Type 1 diabetes, can you use it? Type 1 diabetes, you told for all type 1 diabetes, for postprandial hypertension, can we use it, sir?
Yes, we can use it to blunt the postprandial peak.
Thank you.
If there are no more questions, I take this opportunity to thank Professor Dr. Shashank Joshi,
Thank you.
Dr. Jyoti Dev and his entire team for giving us this opportunity to chair this session. Thank you.
Thank you, Dr.